All right, so let's get started. Hi, everyone. My name is Sudipto Srivastava, and I will be your host today. But more importantly, we've got an amazing sort of panel. It's funny how technology evolves or how the industry evolves, because the first time we had this session, which was in April, we described it as, hey, this is like Clubhouse with video, and it's in the morning. And in the last 2 months, like Clubhouse has lost so much favor. So I don't even want to call it Clubhouse. Like, their stocks are tanking and a lot of the usership is gone. So this is the virtual sort of panel. And thank you, Ben and team, for putting it together. Um, you know, I we're going to discuss the topic of remote patient monitoring. I'm going to assume that people know enough about it or have had a chance to sort of Google it. So we won't go into the definitional part of it because we want to sort of get right into the meat of things, because there's like 1,000 different versions of this. Like people can, you know, uh, describe it different sort of ways, and there are multiple facets that pop up. But we've got an eclectic group that has gotten together, and I think listening from their insights will be helpful. I'm of course very bullish on remote patient monitoring. I feel that it's going to have a similar trajectory as telehealth. But there's a lot of facts and fictions and past stumbles on RPM, and this group that we'll hear from has had an experience, like a front row seat in sort of driving it into the unknown future of RPM. So we'll actually have our panel that we're going to speak with introduce themselves in ascending order. I do want to sort of call out at least one person who will introduce himself, who is in a time zone where it's 5 a.m. So Darryl, thank you for joining so early in the morning. But let's get introduced. Rob, we'll start with you, Darryl, and then Vicky.
Hey, good morning, everyone. Thanks for joining. So my name is Rob Fields. I'm a family doc and currently the Executive Vice President and Chief Population Health Officer at Mount Sinai here in New York City.
Good morning, everyone. My name is Darryl Hollar. I work at Mount Sinai Health Systems. I'm a director on the digital health team. I've worked in various industries, but I've been in health IT for the last decade or so. And for the past 2 years, we've been implementing RPM solutions at Mount Sinai.
Great. Good morning. Hi, everybody. My name is Vicky Tiase. I'm a nurse informaticist and director of research science at New York Presbyterian Hospital. And my program of research has a real focus on how we utilize patient-generated health data. Great to be here.
Well, thank you. So let's sort of dive in. As I said, RPM and remote patient monitoring has had an interesting trajectory. We saw big growth in 2020 during the COVID times and whatnot. I think one thing that we struggle with, and I think the healthcare industry generally struggles with, is like who pays for it? Because of course the cycle of patient, insurer, and hospitals and doctors it's a weird sort of mix, and we've covered that in our past discussions. So I want to actually sort of jump right in and sort of ask pose this question to the panel is to who really benefits the most from RPM, and thus and therefore who should pay for it? So Rob, we'll start with you. Darryl, we'll hear from you next, and then Vicky.
Yeah, it's a great question. So I have very strong convictions about this question, but I would say that ultimately the patient must benefit. Otherwise, there's no point in doing it. If you're doing it purely as a revenue generator, then frankly you shouldn't do it. So it doesn't. If it's not set up correctly, I think there's a potential to actually fractionate care. So I think if you have the idea that the patient ultimately must benefit, then you can design the process to solve some of those issues that actually are synergistic with the care model and not either in parallel or contrary to it. And to that end, I would say that it's not just the tech, right? The tech is in many aspects, I think, sort of the easier part. Although Darryl will probably disagree on that. I think, but the process behind it is important, right? You can do RPM in lots of ways that improves care essentially zero. But if you set it up correctly, it is a situation in terms of who benefits. Of course, the patient is number one, but I think, if you set up correctly, the physicians benefit intensely, the system benefits intensely. I'm a pop health guy, so we're in risk contracts. I mean, I think the pop health enterprise benefits as well, but I think certainly the patient benefits most because we're controlling chronic conditions that are otherwise, frankly, just massively uncontrolled across the country. Hypertension being probably the biggest example. I think in terms of who should pay for it, I guess I would say the risk-bearing entity, to use a more generic term. I mean, I do think that insurance companies, from a business standpoint, stand to benefit the most. But if you're a risk-bearing entity, like we take full risk on many contracts, then we should pay for it. We pay for it anyway out of our medical expense, right? When you're at risk, we're not capitated, we're a global risk. So, we pay through our medical expense dollars because we benefit as a business. If you do this correctly, this is one of those few times where the achieving clinical outcomes, you can see the return on that on utilization pretty quickly. Whereas sometimes cancer screenings, we spend a lot of time doing that in pop health, but the return on that is actually measured in decades. Something like remote monitoring, you can see the return on that in months, frankly, in terms of doing that correctly. So I think I would say the risk-bearing entity should pay for it. But certainly defer to my colleagues and see if there may be other opinions out there.
No, I totally agree, Rob. Various stakeholders have the opportunity to obtain value here. Everybody's going to benefit from decreased costs, reduced travel, more engaged patients, and better access. But to your point, patients are going to benefit in a lot of ways. The high risk, borderline, uncontrolled patients are going to see value. But I think the chronic care patients, which Rob, you know intimately, I think they're going to see value in the fact that they can send data to their providers on a daily basis and get better insights into their conditions or their disease, that how it's being managed and how it's progressing, and even just peace of mind. We have an RPM program at Mount Sinai, and at one point our patient navigator reached out to a patient, and because their alert came in above the threshold, and the patient was even just surprised and said, hey, this thing really works. Somebody's actually looking at my readings. They just thought it was going into a black hole. But the point of somebody is helping me manage my care in between visits was a shock to them, and they just felt comforted that they weren't alone. So I think patients are going to benefit in a lot of ways. Hospitals and insurance companies, as you mentioned, Rob, I think they're going to benefit tremendously. Ability to just discharge patients home more quickly, ED avoidance. I think enhancing the fidelity of the telehealth visit is going to be key as well. The more we do telehealth, having tools and devices in the home that could help support that, I think that's going to be key. And it fits a need in this COVID world that we're in. If we need to be remote again, and then also it could serve as a barrier to competition, because we know what's coming from different organizations in different industries. So I think there's a lot of benefit all around. And the way I sometimes look at it is that maybe not who should be paying, but I think there are a lot of entities that should want to pay for this, that should want to progress this. And I think maybe in the near term, some entities, payer insurance companies, may see this as driving additional volume into the system, because people who weren't going to get care may now seek care because it's easier. But I think in the long run, it's just going to reduce costs and load on the system overall. So I think that entities should be looking at it from that standpoint and getting into I want to pay for this versus I have to pay for this.
Great. I wholeheartely agree that it's the patients that will ultimately benefit, but I'd like to get a little more granular on that. So I think, we're noting that it's really our rural patient populations, which aren't always the first places we go to implement remote patient monitoring, right? So it's looking at those states and parts of the country that really have difficulty with patient access and connecting with patients regularly. And then secondly, as Rob alluded to, it's really our chronic disease patient population. So I think that's the other important piece to remote patient monitoring. I fear that sometimes we go straight to the patients that have the technology already or who are already adept at the technology, when really it's going to be important to shift our thinking a little and figure out how to reach those patients that really need it and that will ultimately receive the greatest benefit from it. In terms of payment, I certainly agree with the comments so far. I think connected to that, I just wanted to make a couple of points. I think one, and we're already hearing it from the conversation, sometimes I have to explain that telehealth does not equal remote patient monitoring. And if you're billing for a telehealth, you are not billing for remote patient monitoring. So recognizing that today they are separate billing codes. So we do have, some precedents there in terms of being able to bill for it. And then I think the other piece when it comes to payment, which I think is important to consider with remote patient monitoring, is being paid for the reading and the interpretation of the data. So right now, for CGM, so for continuous glucose monitoring, that's the only use case today where providers can bill and are incentivized to read patient data and get credit for that, if you will. So I think that's just a bigger piece to think about. What exactly are we looking to get paid for, or who should be paying for what? And then connected to that, I think a part of this question is also the incentive piece, because I think figuring out what those incentives look like in terms of the payment model, right? So, there have been some conversations around, well, if patients are using remote patient monitoring, should they get some sort of, benefit in their insurance payment? And what does that look like? So I think including incentives in that payment conversation is very important.
Yeah, that's a great point. In talking about incentives, the FCC has been doing their part in sort of greasing the wheels a little bit by putting some money out there for telehealth, remote patient monitoring, and so on. And I know a lot of our organizations have benefited from that, as have many sort of rural organizations. So I think there's certainly a desire to go that way. As we do with these things, and I think the power of this kind of forum is we also take questions from the audience. So there are certain questions that I have in my head that I want to ask the group, but when they start sort of coming in, I'll sort of filter those in. So maybe Darryl will take one of the questions and go with you, and then Vicky, and then Rob. And I think the question is, how do we make patients comfortable with technology monitoring so that it's not hyper monitoring? So it's an interesting twist because, and I like that question because most often we think as health systems of, from an inside out perspective, what does it do for us? How does it pay for us? How is it taking our time and burdening our doctors and our nurses? And so I've never sort of thought of it in this way as to how is it burdening sort of the patient? Maybe that's sort of the intent. Has this been answered? But let's take a crack at that and see if we have some thoughts on that.
Yeah, and I think what we've also heard in regards to that from our patients is that we shouldn't treat it like it's a device. It's not another device that we're giving to the patient. We should be thinking about it as how it impacts the patient experience, how, talking to them about the benefits of how it gets better access or promotes better access to their providers. It's almost like, the way Apple treats their commercials. They're not even selling a technology product anymore. They're selling the experience and what you can do and how you the value you'll get from it and the benefits from you get from it. So when we talk to patients, it's not just that we're going to give you a blood pressure machine or we're going to give you a glucose meter. We're going to give you the access we're going to give you the ability for your provider to check in on you on a regular basis and then respond to you if there's an issue.
Vicky, any thoughts on that? And Rob?
Yeah, absolutely. I certainly agree with that. And I would follow that up with, again, specifically, I find that nurses are, as the most trusted provider, are the ones that are really interacting with the patients and their families and caregivers and, fielding a lot of those questions And I think you're right, Darryl. It's more about that relationship and making sure that there is education around, whatever we're providing to the patients, that they have an ability to answer questions. There's been some great examples of organizations that have set up nurse call centers, because a lot of times when the patients are asking questions, it's not just technical in nature. There are truly health-related questions that a clinician is needed to field those. So I think, yeah, that's exactly it, making that connection between the relationship, the experience, and that just because we are deploying technology, it does not take the people function out of that.
Yeah, I couldn't agree more. I mean, this goes back to the technology isn't everything. You got to have relationships. Healthcare is a relationship business, no matter how you frame it. And so I think that is the key to getting folks engaged. Having said that, you're still not going to get everyone. There are folks that distrust the system, in air quotes here. They may distrust technology, et cetera. We have examples on both extremes. And in a lot of it, going back to Vicki, something you said earlier, is patient choice or selection for these sort of programs. So we've had examples in the post-COVID period where we were doing some remote monitoring, where we had relatively healthy-ish people that happen to get COVID, and you're in that indecision time in the ER, should they come in or not? And one of the things that we started in that time, somewhat experimentally, is, all right, can we discharge folks home because our hospitals are overflowing? This is last spring. Send them home with a pulse ox. Well, what's starting to happen is that the pulse ox was going off left and right, and we had a couple examples of folks that literally threw it in the garbage, say, please unsign me up, take me off the list, because I don't want you calling me every time my pulse ox goes to 84, because reality is, it's going to fluctuate. They were sick, but not that sick in reality. Like, it just didn't match the clinical scenario. The number didn't match. I have the same fear, frankly, about Apple Watches. We've all heard the worried well, that all of a sudden, the reality is that we probably have minor arrhythmias all the time. We just don't know it. And as soon as you put a watch on there that tells you that, you had a PVC or something like that, fire, then you freak out and go to your doctor. And it's that sort of scenario. So patient choice is really important. In general, what we have found is the sicker patients that not only have uncontrolled hypertension, but also diabetes and heart failure and all these other conditions, often they don't get enough touch. So once we've established the person relationship with the pharmacist or the navigator, it's actually gone really well. Like, they enjoy the ability, the reassurance that someone's there, and it's again, not just a technology, but there's a personal touch that someone's looking out for them. Again, you're not going to get everybody, but once they have a few positive examples, it tends to scale on its own. But yeah.
That's great. Shannon, I know you had a question, and Rob answered that in chats, but if you need to discuss that more, just pop in another question, and then we'll go from there. So I think we've discussed a lot around sort of payments, who pays for it, a little bit around patient sort of part of it. I want to, it's remote patient monitoring has also become kind of like the buzz. And even though it's not new, I mean, we've been monitoring patients for years and years and decades, like with Hollar monitors and whatnot. But there is a certain desire now. Technology has evolved a little bit. Of course, last year with COVID, people saw, the power and the value of things. So there's certainly a lot of sort of bullishness and, maybe frothiness also in the market. But at a practical level, I'd like to sort of get your perspectives on, like, what do people miss out the most as they plan for their, RPM expansions, out, whether it's a large health system or, which is sort of represented here, or as clinicians are sort of looking into this thing. So Vicki, will sort of start with you, then Rob will hear from you, and then Darryl.
Right. Great. Thank you. So I think, gosh, there are a number of things. I'll try to keep the list somewhat small. So I think one of the big ones, as I mentioned, I am, super interested in how the data flow and how we as clinicians get access to the remote patient monitoring data, and can use that to decrease documentation burden, to create efficiencies, et cetera. So I think one thing that we sometimes miss is understanding how that's going to work and what the vendor has put in place to ensure that interoperability works smoothly. And I think that is on not only the patient end, but also the clinician end. So what is the effort on the part of the patient to, I'll say, upload the data? So I'll use that term loosely. So does the patient have to do any sort of active upload of the data, or do we have some passive data collection going on, right? So a lot of the sensors are passively collecting, whereas with some of the other devices out there, the patients actually have to do something to make sure the data are transferred in a way that the clinician can see it. And then flipping to the clinician end, I think making sure that we have easy ways for the data to be summarized, contextualized, and visible within our clinician workflows. So I think that is it's huge. And there are a lot of pieces to it, but I think there is a ton of work to do in that area around interoperability, standards, and workflows. The second piece, which I touched upon already, is involving the clinicians that are going to be interfacing with the patients, right? A lot of times, and again, this was out of necessity last year, we really pushed out remote patient monitoring and didn't have the time, quite frankly, to do the due diligence and understand, all right, which clinicians are going to be responsible for this? Do they have other responsibilities, and how are we going to work this operationally? In my organization, I found that the nurses were the ones that were calling the patients, trying to explain the devices to the patients, and that teaching piece was so important because we really got so many calls after the fact. So I think really thinking about all that ahead of time and making sure you've got all those pieces in place before your solutions are implemented. And then the last piece, and something that I'm working on studying right now, is really understanding the patient populations and their needs in terms of health literacy and just general literacy in understanding how to use the technology and making sure it's in a language that either they understand or that their caregivers or their families understand. I think sometimes we might leave them out of it, but understanding who's actually going to be using the technology on behalf of the patient, perhaps. So those are some of the big things that I think about and that I'm concerned about as we move forward. Again, ensuring those pieces are in place in order to have success with RPM.
Yeah, I couldn't agree more. I don't know that I have a ton to add, but I would say our experience has been, and Vicky alluded to it, is workflow is all that people look at sort of RPM and the technology associated with it as a sort of the shiny new object. Frankly, a lot of our clinicians, we've seen tons of examples of that. Frankly, even with some of the FCC grants that we got, there's a lot of enthusiasm. Let's get RPM going. There's a potential use case out there, which actually the use case makes total sense for whatever they're planning on doing. And then they forget that now they're going to be ingesting gobs and gobs of data on a daily basis. And then who's actually going to look at it? Who's going to make a clinical decision? What if it's an emergency? What if it's 10 o'clock at night or Saturday morning at 10 and nobody's around in the clinic to address it? Those kinds of workflow issues. And Vicky, to your point, who's going to talk to the patient and how are they going to talk? What's the messaging to the patient on how to interpret these numbers they're seeing? Who's going to deal with the technical support? I mean, the list is endless, and these are all workflow issues that are related, but frankly, independent of the integration, questions that we all have about how, the technical parts. So I feel like that's the biggest thing to consider. I would also add, if RPM is going to be a thing in a large system, you have to have a sustainability plan. Because otherwise, what will happen is once the novelty, frankly, wears off, it's not enough to be. This is going to sound awful, but here's the reality: it's not enough to be clinically relevant. It has to be, financially relevant to the system, at least to break even, so it's not viewed as a cost center. Because inevitably, what will happen is that somebody in the financial world is going to have to make a decision to invest or not if you want to do it at scale. And we all realize that doing this at scale is not cheap. And so, I think there has to be some model of sustainability to at least pay for itself over time. And honestly, and I'm, again, pop health person, all about risk, but it has to pay for itself, frankly, at this point in a fee-for-service basis first, and to allow it to scale, because in hoping that you see the ROI on the risk basis down the road. Otherwise, I think it really gets defaulted into a project and not an enterprise solution.
Yeah, and just picking up on that point, Rob, I think a lot of large healthcare systems that are looking to do this, as you said, at scale, at the enterprise level, a lot of large healthcare systems are leveraging system investment for this. And in Sudipto, to your earlier point, the FCC is putting a lot of money into telehealth, virtual care, and remote patient monitoring. And we have the question often: what are they going to do after that funding runs out? Is it point source funding? And are we going to be able to have a sustainable program after that funding runs out? So, and the reimbursements from Medicare, it's not going to be enough to sustain a program with all of the operational costs that are there. And I would even start a step prior to, I know the question was about RPM expansions, but even in regards to the initial entry into RPM, and Rob, I think you mentioned this in the beginning. What we tend to see is that the focus is solely on or about the device, and we really not push back, but we really try to make the conversation about clinical objectives. What are your operational methodologies? Do you have people and staff to support this 9 to 5, 24, nights and weekends? And then, the technical specifics about how data is going to get back to the healthcare system. And then a lot of times that funnels down, and that helps drive the device decisions. It makes the device decisions easier, because now you're picking a device that's going to fit all of the use cases, the clinical and the operational and technical. And then when programs are starting, you'll have a lot of doctors or departments that are just doing very small entries into RPM. But when they start to grow past a proof of concept or a pilot, you're starting to think about things like threshold management across departments. How are you setting thresholds per disease state or per device? You're looking at alert management, especially off hours, and making sure you're setting your thresholds to a point where you're not getting too many messages and alert fatigue. The monitoring of vitals is going to take a dedicated staff. And I think, you're going to have to, at the enterprise level, you're also going to have to decide if each department is going to stand up their own operational support for RPM. And then eventually, or essentially, you're going to have duplication of responsibilities. Each department is going to have to set up things like, device logistics, procuring devices, configuring devices, shipping devices out, customer support, which is a huge thing. It could be everything from technical support, but a lot of times it's, reaching out to the patient to help them understand what their vitals mean, and then even break fix for devices, right? And then lastly, I'll just talk about, billing. The RPM codes that we're leveraging are still relatively new. And I think there's still some ambiguity there, and you'll need people who are going to be dedicated to understand that and interact with Medicare to make sure that you're following you're documenting in the right way. And then you'll need to stay in close contact with your central billing office to make sure that you're analyzing why, or if claims got denied, why they got denied, and then going back to your process and approach and reworking any changes that you need to into your processes. So I think there's lots of things as you expand that you have to think about.
This is fascinating because, I've spoken to so many people, and they're like, oh yeah, RPM, my iPhone works the moment I switch it on. Like, why shouldn't it work magically? And then just you lay it out, and Darryl and Vicky and Rob, like there's just so many considerations to have for it to work in a complex sort of healthcare environment. On a crazy note, so Nick Jeans from Sinai and I record a podcast, and in one of the moments we were like, what, we keep thinking of this concept of like value and other things. What if RPM was sort of launched as a concierge model? Like, let some of our patients pay into this, because if they Rob, you talked about the worried well people, like with their Apple watches and so on. If the AFib alerts are going on, well, let's give them that concierge service, and maybe that starts creating a new model where patients themselves sort of see a value. And I know, of course, this doesn't apply to every patient population. I'm only talking about the early adopters, but that starts generating sort of the data. I know it's sort of crazy and outlandish. But I also want to now take a question from the audience. I think Alex asked, from a payer or provider perspective, how can we leverage new age reimbursement strategies such as value-based bundle payments to better incentivize the adoption of RPM? So maybe Rob, we start with you, and then go Darryl, you and Vicky to that question.
Yeah, I mean, I think that's certainly our justification in lots of ways. We do try to. We have created a model that sustains itself on fee for service, but that's not our end goal from a financial and performance incentive perspective. It's really on the value play. I think you have to believe that this type of intervention is going to reduce total cost of care. So that's the only way. In terms of using those payment methodologies as an incentive, you just have to believe that it's going to work and lead to when you're in global risk or in a capitated system, you only invest if you think it's going to improve clinical outcomes and reduce total cost of care. So you have to believe that first. And that's where I think, again, process and what are you substituting? So if you are, and then which conditions, I think Darryl references as well, which conditions you're choosing, because there are a lot of low value types of RPM out there in terms of chronic conditions, that just because you can bill it doesn't mean you should be billing it or should be doing it. But where the clinical use cases match, then it is really back to workflows. And you have to think about, all right, if I'm going to do RPM, what other methodology is it supplementing or replacing? So in our model, we have clinical pharmacists that are associated with primary care and specialist physicians in the clinic. And the idea is, all right, when we have a trend on blood pressure, for example, that requires a medication titration, the pharmacist is doing it directly under protocol with the physician, of course, but they're doing it directly. So what is that replacing? Well, it's replacing the normal patient experience, which is I have an appointment with the physician, I get an evaluation, a diagnosis, perhaps some diagnostics, and maybe a medication titration or addition, and then I'll see the physician again in months, in most cases, for the next titration. It's very intermittent management of chronic conditions, and in this case, we are creating many opportunities in between physician visits to intervene and manage the condition. And from the physician perspective, it is replacing the normal patient portal message or the 1,000 phone calls back and forth. And we're doing that on behalf of the docs, and it's been a feeling where we're offloading work. So from our perspective, we are replacing a typical poor patient experience that doesn't get to good outcomes with a more integrated, more direct, and perhaps more aggressive, you would say, experience that we think inevitably will reduce a more expensive intervention down the road if the condition isn't managed. So I think that's the way you have to think if you're going to make it work in a risk environment.
Darryl, Vicky, any thoughts?
I actually just wanted to comment on the latter half of this question to better incentivize the adoption. So I think the piece of this that concerns me a little bit is that payment in and of itself is not going to do that. So I think to incentivize the adoption, there are so many issues right now. So I think, one of the biggest in my mind, and again, this is something that I take a look at today, is the reliability and the validity of the devices, sensors, et cetera, used. The research and the evidence is so scant right now. So we really need to build that up. And we also need to present it in a way that the clinicians then trust the information that is being presented, because we could pay and reimburse a ton, but if the clinicians are not going to trust the data that they are receiving and are acting on with clinical decision making, it's not going to work. So I think that whole area really needs to be blown up, and we really need to, make sure that we've got, all of that set up. Our sensors, we're still struggling in this country on how to regulate and label sensors, and which ones should be used, which ones should not be used. And then I would say the other piece to the adoption is something that isn't always touched upon, but is also the legal and regulatory aspects around it. So I think a lot of organizations are still struggling with this and what it means from a malpractice perspective for clinicians to act on data from a patient. How do we tag that differently in the electronic medical record? And what does that mean if a clinician makes a decision based on patient data, and what protections are afforded if there are issues there? So I think there are a lot of barriers to adoption. I am all for moving forward remote patient monitoring, and I think there's a lot of value, but I still think there are many more barriers to tackle outside of payment. And I see a lot of discussion on payment. I just felt like I needed to chime in with the other barriers that I think are a lot more.
I have to say, this has been by far the most active sort of chat group. So having this is great. Darryl, any thoughts before we another?
Yeah, quickly. On adopting disruption, I agree with Vicky. The patients are going to have to see value for this, and a lot of times when I think about adopting disruption, I think about Netflix and Blockbuster model, and one of the key things there is not just that they were mailing DVDs to patients, but they were interacting with the patient more on a regular basis. And to Rob's point, when you go to Blockbuster, you go every once in a while, and they don't collect any information about you. When you go to Netflix, the first thing they do is have you sign up for an account, and you're managing, you're telling it what movies you like. And we're going to have higher touch with the patients with RPM on a daily basis. And if we leverage that data to have better conversations with the patient, we can actually message and work with them at a different level than we perhaps could have if we only saw them once every 3 months, 6 months, or 12 months.
Yeah, makes sense. So we're going to put up a quick sort of poll here for our audience to sort of respond to. And while you're sort of responding, Alex, I see that you have a question. I had a similar question as well on this on this topic. So now let's turn from a traditional healthcare doctor office reimbursement sort of setup to more non-traditional. So I'd like to ask our speakers here, like, what are your views on the non-traditional players that are starting to move into this space? Clearly, companies like Amazon and Best Buy, they've smelled blood. They know that there's value here. So what are your views on these kinds of companies that are coming in? Is that good, bad, like whatever that creates from a dynamic sort of perspective? Darryl, we'll start with you, then with Vicky, and then Rob will hear your views. And Alex, hopefully this kind of starts answering a little bit of your questions as well around wearables, Apple Watches, sharing data, and so on.
Yeah, I think it's inevitable that those players are going to come into this industry and start to get a foothold here. Healthcare is becoming more consumer-centric, consumer-focused each day. Consumers and patients are have liquid expectations, so they're going to want a similar flexibility and personalization of services that they see in other industries. With Apple and Amazon, the ability to get next day, 2-day, or 2-hour delivery of goods to their doorstep, they're going to have that same expectation with healthcare and say, I want that same experience from my healthcare provider or organization. And again, the consumer-centric workflows, they want the services to flow to them wherever and whenever they are, right? So I think it's going to be about multi-channel, making sure you have services that reach patients wherever they are. So it's not about telehealth replacing the in-office visits or RPM replacing something. I think you have a multi-tiered strategy such that you can reach patients in different channels or mediums, depending on where they are at that point. And I think it started with the digitizing medical records and EHR adoption 10 years ago. And with the pandemic, it's increased the patient's willingness to receive healthcare in new and different ways. So, and companies like Amazon, Best Buy, they have strong relationships with the consumer. And I think they're going to capitalize on that. They're going to look to capitalize on that. And in addition, the things that we call consumer devices now, I think more and more they're going to add clinical sensors or clinical capabilities. It may not happen overnight, but I think every few years you're going to see another clinical grade sensor pop up in a device, and it'll start to blur the lines between those devices. So, you know, the research says that we should expect 20% of care to be delivered virtually in 2021, 30% in 2022. But I think it's going to be about who does a better job about, like I said before, innovating around that experience. Such that RPM is seen as part of their lifestyle and not just another device that they need to carry around.
Great. Vicky?
Yeah, I love that, Darryl. That's exactly where I was going to go with this. I would even take it a step further, that health is not something separate from their life, right? I think that's the change that, you know, 25 years ago, that's why I went into healthcare, because I, you know, wanted, you know, to make an impact and have other, you know, individuals, other humans live their best lives and consider health a part of their life. And I think that's exactly what this could do by having these other non-traditional players moving into the space. I would say the other big advantage, and we're seeing it with Amazon already, is on the legislation and advocacy front. Right, so some of the states that have been slow to have providers working at the top of their license, to moving forward telehealth, to a lot of different pieces in healthcare, not just related to remote patient monitoring, but you know, they've got the dollars, and we really need them to help push this forward. So Amazon, you know, Amazon Cares has a vested effort in seeing this succeed. So I think for me, I'm really excited about that. And, you know, some of the organizations that I work with are already starting to partner and work with Amazon to figure out how we can move the needle in some of these states that have been a little behind. So I think I'm all for it and excited to see where this goes.
Yeah, I mean, I would say I'm certainly all for it for all the reasons everyone said, with a high degree of caution of, you know, I think everyone thinks they can figure out healthcare and do it. We have lots of examples here with large companies trying to figure out how they're going to use their leverage to quote unquote fix healthcare and have failed almost universally. However, in this space, in terms of the technology, for all the reasons Darryl and Vicky said, I think it's good in terms of getting movement, and I would maybe couch it all as normalizing this as a part of the experience in healthcare. I think it'll go a long way. I think concretely though, in terms of increasing you know, adoption and how to make it feel, I think this is also sort of vital or essential in the chat. I think that you know, this is probably a comparison that's being used over and over again, but I think about my first iPhone and not really understanding all the use cases until, you know, you had it for a bit and you have to experience it before it becomes, again, normalized and what most of us would feel is sort of essential. And so I think, so just yesterday, we had an example where we had an older woman who's enrolled in RPM in our institution, was noted to have variable blood pressure readings, like widely variable, like exceedingly high and then exceedingly low. Flagged the pharmacist that, hey, that's an issue. Called the nurse practitioner at the primary care physician's office, who then initiated a community paramedic to go out to the home and evaluate the patient, who was noted to be in new onset atrial fibrillation, which is an arrhythmia that can cause a stroke. Was then taken to the emergency room, And in most cases, in that situation, the risk of a stroke she was 90 years old, by the way, by the time she entered the hospital. So it was on her 90th birthday. The risk of stroke is significant, or maybe not quite as dramatic a stroke, but certainly with labile blood pressures, could have passed out, could have fallen. And you imagine all the different things that could have happened to an older person at home alone with this technology. The more experience, you're going to bet that her family at this point, knowing that this was what flagged it, is going to feel like this environment, this technology was essential to her care. And they're going to ask about it when they experience. And then you scale that across the board. The more experiences like this that folks have, the more essential it will become in understanding how to put it into context. I'm not sure that Amazon alone can do that, but certainly the scalability of something like Amazon or Best Buy, along with, I think, real experiences of what the use cases are, will help significantly.
That is such an amazing story. I mean, these are the kinds of stories that just, of course, give me goosebumps and feels excited to be, in the industry that, we're all in and are excited and bullish about. So this is great. We'll take one other sort of user question as we start getting towards the 9 o'clock hour and people start the rest of the days. So Doug is asking, what are the biggest RPM use cases? Is it blood pressure monitoring, glucose monitoring, temperature monitoring, and what's next in the horizon? Like look into the future, movement, hormone levels, psychological status, and so on. I think the answer is like all of the above, yes. but let's sort of hear maybe Vicky from you, and then Rob and sort of Darryl in that order. Your thoughts?
Sure. So a lot of the research that I do is with pediatric asthma patients. So in the pediatric or in the adolescent population, the asthma patients are huge users of mobile health devices, remote patient monitoring. And I think this is sometimes overlooked because it's really these younger generations that I think are going to be pushing the needle on this, right? So these I'll say adolescent asthma patients are expecting that their providers are going to look at their data. They are expecting to get responses back from their providers. And when they don't, they're not very happy, and they'll see if there's another provider that can assist them. So I see some great opportunity with the asthma population, because we now have sensors that we're testing in the home, where we are working with families to place sensors either in the child's bedroom or in the living area, and looking at the levels of pollutants. And then also triangulating that with the patient's symptoms alongside the environmental situation. What's the humidity in the air today? So I think there's a lot that we can do around asthma. So I am excited to see that move forward. And like I said, I think ways that we can, test in the younger populations, I think is going to be important, because that's what we're going to be seeing, or we need to prepare for in the years to come.
No, I agree. I think in the pediatric world, it's almost certainly asthma from an RPM standpoint, everything from all the devices that he was just mentioning to also, I would add peak flows to that, and all those devices in terms of ongoing monitoring. In the adult world, it's hypertension, hands down. And maybe that's surprising that it's not diabetes, but, on the adult side, what's often said on the public health side, if you're going to account for or aggressively address one chronic condition, it's hypertension in terms of its downstream effects in terms of clinical outcomes and then total cost of care on both counts. So hypertension for sure, although diabetes is certainly in there. I will say the tricky part on diabetes is that more and more, unless you're a type 1 diabetic, if you're a type 2 patient with diabetes, you're really focusing on aggressive medication management and A1Cs. It's less sort of like the daily minutia of sugar. In fact, a lot of the guidelines have reduced the number of sugar checks per day for many of our patients with type 2 diabetes. So it's less the day-to-day management and more long-term management. So I think for that reason, again, hypertension probably rises as number 1 and 2 on the list on the adult side, I would say.
Yeah, I agree. We're deploying, and we talk to other healthcare systems, and they're deploying blood pressure, weight scale, like Rob said, glucometers, pulse ox, temperature, EKG, and I think an area that's going to grow a little bit more, maybe those multifunction patches for post-discharge patients. Oftentimes, a person will be discharged, they may be sick, they may not want to monitor and put on a device multiple times per day. So having a patch that can just stick to their body, last 14 days, and has multiple sensors on it is often very useful. In the longer term, we're looking at devices becoming smaller and more passive, and being able to sense at a distance. There are companies that are actually even designing them to be a fashion statement, right? So that they look like clothing accessories. And Harvard is developed a smart tattoo that places a health sensor in your skin. Now, all of this stuff is in research and development, but again, I think it goes to the point where I think eventually it's not going to just be seen as a medical device, but it's going to be something that will integrate into your lifestyle. So I think the future is going towards miniaturization and passive monitoring as much as possible.
Lovely. I see a lot of questions, but I want to sort of start wrapping up on a bullish note. I do want to point the audience to a poll. So if you, I think there should be a poll link. If not, we'll put it up again. We would love that feedback for future sessions, and what worked, what didn't work, and so on. So if I could request the producers to launch the poll back again, thank you. And I'll also start with the next sort of caution I had, and maybe we can wrap up on this, is almost like prediction type, hype versus reality. RPM is definitely in the classic hype cycle of things, is trending up. Gaze into your crystal balls, and we'll start Rob with you, and then Darryl, and then Vicky, like quick snapshots of where do you think the industry is going to be 5 to 8 years from now? I know Darryl gave a little hint around digital tattoos and so on. We had a futurist come and talk to us at our organization, and their tattoos were definitely there. We also talked about the public fearing that vaccines have chips in them and what that does to them. So there's like a whole mindset you need to align on. But let's go hype versus reality. Where do you think the industry is going to be 5 to 8 years from now?
Well, I would say that we're seeing hints of it already, but I think, and I just mentioned something in the chat on continuous data with things like Apple Watch and the role of AI, and I think that's going to be the pairing that we're going to see next over the next few years. And so we're going to have devices in the home with varying amounts of intermittent versus continuous data flowing into it, and then having an AI front end essentially that's looking for signals and trends, because oftentimes its individual data points are less helpful for many conditions. There are exceptions, of course, but I think we're going to see more AI front end with perhaps a chatbot, or some sort of, even if it's on an Alexa or something like that, to have conversations with patients to pre-screen and assess current symptoms and try to figure out, does the data make sense? Going back to the example of the patient that got mad and stopped his pulse ox, it turns out he was fine, right? So what if an Alexa said, hey, we saw your pulse ox was 85, are you feeling okay? And the dude's like, yeah, I'm fine. I just, I had a coughing fit and now it's better. Then they would have been done, right? Instead, literally EMS showed up at this person's door because we couldn't get a hold of him. And that's when he was done with the pulse ox. So I think there has to be I think there's going to be AI facilitation of some of the stuff. And then with healthcare providers on the back end, of course, as an escalation path. But and we're already seeing it, folks like Babylon and others that are in the market using AI front ends to and chatbots to assess symptoms and then escalate and triage appropriately. I feel like that's what we'll see next.
Darryl.
Yeah, no, I agree. And I think the pandemic changed the pace of adoption for a lot of the healthcare technologies. So RPM, in the span of a few weeks or months, went from people questioning the true value of it and asking if it could work at scale, to being on the path of mainstream approval. So we have to see if this rate of adoption will continue. But I definitely think in 8 years, clinical devices in the home will be commonplace. For some reason, I just feel that this form of disruption can take hold and grow rapidly. And the things we call consumer devices will have hospital grade sensors in them, or clinical grade sensors in them in 8 to 10 years or so. And there's already devices that are touting this, but they're really expensive or too big. But again, I think the device is going to become smaller, more passive, able to sense at a distance. And I think that's where we're headed toward in the future.
Vicky, bring us home.
Well, I certainly agree with Rob and Darryl. I'm not sure about the 5 to 8 years, though. I'll be a little bit of the realist here. I think with the struggles that we've had over the past decade of trying to get interoperability across the country up and running, I still think we have some real fundamental items to work on. So I'm hopeful. While I completely agree, we're going to see the devices, really explode, and I think the technology improve. I think there's a lot of research and great engineering going on right now that will be a great benefit. But I think at the same time, we're really going to need to focus as an industry on the interoperability pieces. I'm super excited to see what happens with the open APIs that are starting this year, because I really think the X factor is the patient, right? So we need to get to a point where the patients expect to have their health data, expect to have it all in one place, expect providers that are going to engage in feedback about their data, and also be able to essentially monitor their own health outside of the clinical setting with ease. So I think we can get there. I think it's a matter of getting the patients to expect it and demand it, and fingers crossed we can get that all to work.
I love it. You're already queuing me up for ideas for the next sort of discussion, like the 21st Century Cures Act, interoperability. Those are big topics to consider. Shannon and Suzelle, I know we weren't able to sort of get to your questions, but we're at the end of this thing. Thank you, of course, to Vicky, Rob, and Darryl for I learn every time I speak to all of you. So thank you for that. I also want to sort of call out some unsung heroes. Lila, who's been our producer for this show. There's just so much back end work that happens to make this all work sort of smoothly. So Leila, so thank you for doing that. And of course, Ben and Lacey, who put this together. So thanks a lot. I'm going to hang around here for a few seconds if anybody else wants to. But have a wonderful Friday. This is fascinating. I'm excited and pumped already.
Thanks all.
You.